right, moving on. Good afternoon, all. I'm actually delighted to be here with you all. I actually speak at a different pace than Helen, um, but I think that's okay. So this is, as was mentioned, I am a federal representative, but this is my disclaimer that I'm obliged to show you. But let me start with the questions that were actually posed to us in preparing for today's panel. And as we're thinking about measurement, the question is, so improvement or refinements, how might improvements or refinements to measurement facilitate shifting payment model and also shifting payment models facilitate improved care, that is for patients with high needs. And so my comments as I go through, I will focus on how some of these measures are used, and that can hopefully illustrate the opportunities for improvement and attainment of desired outcomes. It was earlier mentioned that context matters, and we are amidst of a reforming delivery system. We are focusing on better care, smarter spending, healthier populations, and following the Secretary's charge for doing so by paying for something different, that is value as opposed to volume, right? That we will be providing that care differently, which is the care models that was mentioned and highlighted in the title of this work series, but also that we would be sharing information, distributing information. So I think the conversation that you're having here really fits squarely into the opportunities that delivery system reform presents, and calls attention to how we would do this in a way that best meets the needs of the population of focus. Back in 2015, CMS provided a contextual framework for categorizing payments to providers, that is, payment models, and also the care models that would be forthcoming. CMS is an operational agency, so this is how we have operationalized the current state, which was we're moving fast away from, which is fee-for-service. The second category of which is that care and services would somehow be tied to quality, and that is the quality discussion underway today. And that would include value-based purchasing programs for hospitals and physicians, but that we would then move towards alternative payment models that include accountable care organizations, medical homes, and the such that were discussed today. Now, in categories 2, 3, and also 4, which is population-based payments, that quality is an integral part of the design and the construct. So most, if not all, of our care and payment model tests or demonstrations are conducted under the authority of the CMMI, which is the Centers for Medicare and Medicaid Innovation. And I will this is the CMS Innovation Center portfolio, and you can see that the models themselves are divided into buckets of how we pay for care differently, that is paying for value, how we would deliver care differently, and also importantly, distributing information. I will tell you that as we look through each of these models, and I won't take you through all of them today, I think the take-home message is that we have quality integrated into the construct, into the fabric of these models. But quality may look different, and it should look different depending on what the construct of the model is. As an example, and I'll give you 2 examples that illustrate that. Importantly, also though, not just what the measure is, but how the measures are used will vary by model and over time, and how the measures are used to incentivize are subject to intense analytic processes, but also applications of weighting that matter. And if you look at any value-based purchasing program, whether it's hospitals or the forthcoming and emerging quality payment program, you will see that there are weighting algorithms and weighting methods that are publicly available, and those are required in order to set cut points of success, set what is optimal, set national benchmarks, and compare progress to. Now, importantly, there are some core measures that run through several of these programs, and they are focused on safety, such as poor control of diabetes rather than optimal control of diabetes. Again, balance required there. It would also include things like vaccinations, which you can find a rare exception to who should not be protected in such a way. By and large, though, that there are core measures that beg the question, can we do better and measure more of what matters to this population? I would agree that there is work to be done, and it is predicated on the evidence that comes forth to provide the quality measure characteristics that are optimal, that are useful, but also to ascertain how best should those measures and could those measures be used. Now, this is one depiction that is on our multiple chronic conditions dashboard constructed in 2012 based on CMS administrative claims fee-for-service data, just illustrating the point and recognizing that function is not on this map. What is on this map is simply a compilation of the number of chronic conditions, but you can see with the number of chronic conditions, so goes fee-for-service expenditures. And with that, by the way, we also now know that with number of chronic conditions, increased complexity, so goes increase in adverse drug events, mortality, hospital readmissions, and emergency department visits that could be avoidable. So this is a population that matters significantly to CMS, and this actually helps us connect the dots between population needs, coordination that's necessary for all of the care and keeping required, but also when that does not happen, it translates into unnecessary readmissions, hospital admissions, avoidable events, and emergency department visits. So Helen mentioned, the importance of quality measurement and how it can be used and how we would ultimately desire measuring what matters. As you review the portfolio for the Innovation Center and the work underway in the programs that CMS is putting forward, you will see that we are fulfilling the mandates of quality reporting, that is, to be able to provide fair comparisons with like entities, so comparing one hospital to another, one skilled nursing facility or nursing home to another. But those data also exist to permit the measurement when it comes to the physician and outpatient space to measure in a way that is not necessarily disease specific. So there will also need to be quality measures that address specific high cost, high prevalence conditions, but to create the balance between optimal and safety. Classic example, diabetes management, erring on the side of focusing on avoiding harm, avoiding poor control, and also not cresting into the other end of the spectrum, which is hypoglycemic emergency department events and the like. Now, it is very important to note that we're focusing on aligning measurements across care settings in a more person-centered approach. I will also parenthetically note that every quality measurement technical expert panel now that CMS holds and the development and testing of measures includes patient, family, persons who are not healthcare providers, and the nature of the measures which are thought to be important to move forward really is influenced and shaped by that perspective. We also, though, note that we must capture measurement at multiple levels. So in the construct of the care models, there may be models that focus on individual providers or focus on small provider groups or larger groups or systems or care partners, such as what happens in the hospital to post-acute care. Measurement has to suit the purpose of the program. So you will see that there's variability in how the measures are constructed and how they're used based on the nature of the program. And of course, important to remember that the measures, when they're used, can be used for quality improvement purposes, but also reporting, benchmarking, and also value constructs. And we do focus on measuring to improve. So this is just one example of what's in the Innovation Center portfolio, which is the Comprehensive Primary Care Plus initiative, which is newer, one of the newer developments since this group last met. Focus on the following, that the construct of this comprehensive primary care profile would that it provides greater access and continuity, better care management opportunities, coordination, patient and caregiver engagement, as well as planned care through population health. Importantly, these components also need to reflect measurement. In track 2 of CPC Plus, patient-reported outcomes, there's opportunity to integrate those patient-reported outcomes, and also care plans. So I think that is another really true emerging opportunity for what a good care plan looks like. Joanne Lynn's been talking about it for quite some time. Operationally, would be great to be able to measure and create measures based on this. Important to also note that CPC Plus will be focusing on certain high needs populations, such as those with complex health needs, and also requirements relevant for people with dementia and their families. So that is emerging. A very different type of payment model and care model, though, is the bundled payments initiative. And here the measures are very, very different because the purpose of this is to try to consolidate and coordinate care across care settings. And this is an example of an episode-based payment, an episode-based quality construct. But here, too, we have inserted the opportunity for voluntary collection and submission of patient-reported outcome data. So these are two examples of models that look very, very different, and yet both have quality. The quality construct has to suit the purpose of the model. Comprehensive primary care is trying to test that if you actually break down the silos and have a practice that focus on the needs of the patients differently rather than piecemeal by volume, and in contrast, the comprehensive joint replacement model is synthesizing across care settings. So I am now moving into the area of challenges and opportunities. And I'll let you, they're both challenges and opportunities for each of these. So just to point out, it's our belief that the Impact Act of 2014 is a tremendous opportunity in that in this act, although focusing on post-acute care measurement, importantly requires standardization of data elements across post-acute care settings that include and focus on function. So that includes mobility function, self-care function. The hardest one we have is that of cognitive function. Because, you know, and there the evidence and what the construct is very, very challenging because we would like the measurement, although standardized, to be able to suit multiple purposes, right? Including the original intent of these measures, which is to be able to provide fair comparisons between like facilities and also over time so that patient discharges can be better targeted to the setting that provides the best care. and meets the needs of the patient. So this, though, also creates opportunity for standardization of other elements, such as what would be critical to capture in a care plan or in a goals of care conversation. Standardization can apply to anything, so can be applied to topics that really matter. In addition, though, we have another model test, which you may have heard of, which is the Transforming Clinical Practice Initiative, which actually starts to address many of the concerns that were voiced this morning about state of readiness of that there's variability in state of readiness in the evolution from volume-based practice into value-driven and patient-focused practices. And importantly, this actually, I can provide you with a link to the Practice Transformation website, but enters you into a community, a learning community that you could sign up to share best practices and share experiences of what has worked, what hasn't, along with a change practice that can support practice redesign to enable fulfillment of the opportunities that we have sought, to be able to understand what the goals of care are and such. And this also, though, helps evolve practices so that they are aware of their patient needs, their practice patterns, and to use data to improve. And that is a basis of measurement. There will be quality measures collected in those practices that receive this type of assistance. But learning how to use the data to inform improvement is an important skill set that also requires evolution. So it was earlier mentioned that there's a culture of improvement, there's leadership for improvement, and this actually likely is not sufficient, but necessary as part of the evolution to focus on quality and providing to the needs of the population we're focused on. And I also mentioned opportunities ahead, which include the quality payment program. Now, the final rule was just published, but importantly, the constructs to really focus on are alternative payment models, that is, advanced alternative payment models, which implicitly include quality, but also the merit-based incentive program, which gives you an opportunity to focus on and be rewarded on the basis of quality and practice improvement, and also use of electronic health records. So opportunities and challenges for measurement, I think there are many. One of the greatest challenges that we have in order to get at what measures matter is the need for data sources. Helen mentioned the PROMISE tool and patient-reported outcomes. We're very much interested and have been working to align the quality measures so that they're consistent across these different data sources, and have started with post-acute care. Whatever we do, we have to measure in a way that's applicable at many levels, use the data in different ways, but also acknowledging flexibility and is required because there's no one right solution. There's no single patient phenotype. What matters to one patient may not matter to another. So again, flexibility is important. And honestly, when it comes down to knowing what matters and what has worked, it is challenging in the analysis, right? So traditional analyses, this is a great opportunity to develop new analytic techniques that would be robust in being able to identify what has changed significantly over time, despite the fact that there are other confounders in play, such as other policies that have been implemented. But all in all, we believe that there are opportunities that align with the focus of this group. And just to sum up, This includes standardization, what is already underway through the Impact Act, looking for opportunities within the Quality Payment Program, and looking at the Transforming Clinical Practice Initiative as vehicles for change. So with that, I will stop, and thank you for your attention.